Good afternoon, and welcome to Infectious Disease Grand Rounds. There is no commercial support for today's program. The speakers and planners have disclosed no relevant financial relationships with any commercial interests. If you have a question for our presenters today, please hold until the Q&A segment at the end of the talk. If you're attending virtually, you may enter your question into the Q&A section, and a link to the event survey will be shared at the end of the program. Today, we will have a multidisciplinary team to present on CLABSI. Join me in welcoming our team.
I'm Dr. Supriya Mannepalli. I'm the Medical Director for Infection Prevention and Control, and I'll get this started with some introduction, and then I just want to thank all our speakers today for agreeing to be part of this event, because CLABSI prevention is one of our system initiatives and a very important one because it results in patient harm. I will start off with a case. This is one of our CLABSI cases, 68-year-old female patient who was admitted for strangulated ventral hernia and underwent surgical intervention, had a IJ triple lumen catheter placed within 24 hours of admission. She developed fevers and had positive blood cultures 21 days after admission for staph epidermidis from both blood culture bottles. A triple lumen catheter was removed and a PICC line was placed at that time. Staph epidermidis, as we all know, is a common skin bacteria. And we do here at Northeast Georgia Health System post-event huddles. And what we identified were opportunities as listed here regarding central line removal or necessity being reviewed daily CHG bathing, scrubbing the hub prior to accessing, dressing changes weekly, and also a practice of returning blood drawn from central line, the waste, back to the patient. This was a learning thing for me. I didn't know this was a practice. Again, as we get into the CLABSI, the CME will learn more about the importance of each one of these, but these were several opportunities we noticed. As I mentioned earlier, CLABSIs result in significant patient harm, increased healthcare cost up to $20,000 to $100,000 per CLABSI event, and they are preventable. And the bacteria that cause these infections don't have to come from anywhere. They're right on our skin. And the longer the catheter stays, the bacteria that are on our skin can contaminate the extraluminal surface. And through the hands of the healthcare workers or the contaminated hub, they can migrate intravascularly, leading to infections. The longer the catheter stays, the risk is higher. Tunnel catheters have a lower risk because there is a cuff that causes a fibrotic reaction, preventing that bacterial migration. While the risk is lower, it's not zero. Tunnel catheters can get infected as well. And there's several reasons why patients develop central line associated bloodstream infections. There are modifiable risk factors, non-modifiable risk factors. And a lot of these slides are straight from the SHEA guidelines. And poor compliance with hand hygiene. Hand hygiene touches everything. And poor compliance with CLABSI prevention bundles. And certain patient populations, patients who are on dialysis, who have surgeries during their hospital stay, oncology patients are higher risk. Multiple lumen catheters, multiple access, all of these increase the risk. ICU settings increase their risk as well. And so again, there are all of these factors that result in increased risk. And there's certain post-fast factors as well that increase the risk of CLABSI. Neutropenic patients, high BMI, patients on TPN, patients getting blood products, and of course there are other operational factors like reduced nurse-to-patient ratio that have also been attributed to increased risk of CLABSI. I'll be passing this on to Nicole Dunn, one of our IPs.
Hello, everyone. I'm Nicole Dunn. I am a infection preventionist here at the hospital. I'm going to throw a lot of definitions at you, and I'm going to throw a lot of data at you. So please, if you have any questions, ask me later or email me, and I can clarify, because they can get confusing. So a CLABSI has to have a eligible central line. This means that the central line terminates in a great vessel in an inpatient location. Such lines are eligible for CLABSIs until 2 days after removal. So you can kind of think of it like the Foley day. You have that one gap day after removal. That's kind of how you can think about it to make it a little bit easier. A central line has to be in place for more than 2 consecutive days. So we kind of always say you get those 2 first days. We call those your free days. And then after day 3, or 3 days and on, you can get a CLABSI. And that is following the first access of a central line. So a port, you access it and you're using it after you take it out, that can count as a CLABSI as well because you access that port. And it's an inpatient location again, and during the current admission. Such lines are eligible for CLABSI events and remain eligible for CLABSI events until the day after removal from the body or the patient's discharge, whatever comes first. If the patient is admitted to an inpatient location with a central line in place, so think of like your dialysis patients, and it's the patient's only central line, the first day of the access in an inpatient location begins the central line day count, and that makes it eligible for a CLABSI to be called. So there's 2 different ways we kind of look at CLABSIs. You can have an identified pathogenic organism, or you can have 2 matching common commensals, and then you have to have a sign or symptom, so fever, chills, hypotension. So for example, we have a 62-year-old male patient with hypotension, needing pressors, tachycardia, altered mental status, recently diagnosed with a UTI. A femoral line was emergently placed, and blood cultures on admission were negative. 3 days later, the patient develops fevers, and the blood cultures grow MSSA. So that would make this eligible for a CLABSI because we cannot track this back to another site of infection. There are devices that are not eligible for CLABSIs, such as arterial lines, AV grafts, hero lines, patients who are on ECMO, any VAD patients, or any peripheral or midlines, but we will get back to that. So now I'm going to present the data to you. We had 23 CLABSIs in this last FY, and you can kind of see the trend here. We went down in 2023, but we ticked back up last year. So this is why we're taking a closer look to CLABSIs. The organism breakdown, you can see that most were staph epi. And so if you remember, Dr. Mannepalli said that this is a skin bacteria. So maybe think of some ways, how could we prevent a CLABSI from happening from a skin bacteria? So then I dug even deeper into our CLABSIs. We had 5 central lines, 9 PICs, 7 SWANs, 10 dialysis, and 2 of those patients were on CRT, and then 2 ports. We kind of broke it down. Could it be insertion? Could it be insertion or maintenance? Could it be maintenance? So insertion, we kind of went from day 3 and less. So maybe one of those. Then insertion and maintenance from day 3 to day 7, we're not sure, 8 of those. And then 14 were possibly related to maintenance. Could be, possibly. It's not saying that it is. And then some of our findings that we found for our post-event huddles were a lot of the emergently placed lines were not exchanged. Bathing with the CHG. So when we look at bathing for CHG, we're looking at documentation. So we're not saying it was or was not done. It's just wasn't documented. And then our SteriPath devices, and then a major thing is a bath prior to insertion, or the CHG treatment prior to insertion. Okay, and then this is just a nice little graph that tidies that all up. And this is a breakdown by unit. So you can see that our ICUs are more at high risk for a CLABSI. So how can we prevent CLABSIs? This is conclusions from the data that I just presented. We can replace emergently placed lines as soon as possible. Our policy says within 24 hours. Once an alternative site is accessed. And then check your line daily for necessity. Bathing with CHG daily and prior to insertion for elective line insertion, we call this the CHG treatment. And then we can reduce blood culture contamination rates. Dressing changes every week per schedule or immediately when soiled. and then scrub the hub with CHG with each access. So going back to peripheral lines, in the future, this is coming soon, NHSN, CDC NHSN is going to start looking at hospital onset bacteremia, and it does not have to be a central line. It can be any line, and this will be patients who have blood cultures after day 3 that will get called back to us. So our focus not only needs to be on CLABSIs, but bacteremia as well, and how do we reduce those?
Good afternoon. I'm Dr. Zubelevitskiy. I am a critical care doc, and I'm a minimalist. Not in the sense that I don't like to do things, but in a sense that I believe in the first principle of medicine, which is do no harm. And it's difficult to be a minimalist in ICU because if you stick 15 catheters in a patient, you're seen as strong and confident. If you try to avoid that, you're sometimes seen as lazy or, lacking competency. It's a conversation for other topic, but I think it's contributing to our line issue. I have no conflict of interest to declare. And today we're going to talk about history. Not really, but I hope you're all awake. I was also told this reference may not work for all the generations present in the audience. Perhaps it works for people of my generation. So this is 1943, I believe, in Tehran. It's, allies get together to kind of plan how to win World War II. And, Joseph Stalin representing USSR, FDR representing United States, and Winston Churchill representing Great Britain. So FDR once said, the only thing to fear is fear itself, and central line infections. Let me give you a little bit of ICU perspective, and I will try. When I trained a few years ago, central line infections existed. Now we're talking about central line infections, and I am sure that when I retire, we'll still be discussing central line infections. So perhaps we need to find the way to approach it that is a little bit different from what we've been doing so far. Joseph Stalin was an interesting politician. The way he approached his political enemies, he essentially said, "No man, no problem." To rephrase that, that's your ICU equivalent. No line, no problem. I think the only way to assure that there are no central line infections, not having central lines, which then begs the question is, why do we need central lines? So again, if you would ask me 15 years ago, the arguments for central lines would be, well, we can check CVP and will tell us in ICU setting and tell us the fluid status. When since then we've learned, using CVP for fluid balance is pretty much a toss of a coin. So a 50%, you can guess as well as using CVP. So we don't do that much often. And the other fear is extravasation. So the argument is we're using vasoactive substances, and if we use peripheral line, the IV is not functional, it can cause harm. So how safe it is to use the vasoactive drugs through the peripheral line? Back in 2015, this study came out of New York, and they looked what criteria should be met to deliver vasoactive substances peripherally. And there are few criteria. It should be a relatively large vein. It should be the IV should be on the other side from the blood pressure cuff. There are certain locations that are probably not less safe to deliver these active medications, it should be a relatively large IV, and the IV site should be checked relatively frequently. So great study, but can we keep up with all this criteria to deliver it safely? Deliver it safely. Well, we can if we reconsider our practice. Epinephrine is what we use is norepinephrine and Levophed for shock. Traditionally in the United States, in Australia and New Zealand, they use epinephrine for the same indication. If you look at the vial of epinephrine, you'll read there it can be used for intravenous, intramuscular, and subcutaneous use safely. In addition to that, epinephrine is its own reversal substance. If you remember, epinephrine works on alpha and beta receptors, where if it's extravasated, it does the same thing as terbutaline, which is used for extravasations of an epinephrine. So one more reason not to be afraid of extravasations. Now, what do data support? This study done on people who accidentally injected the epinephrine injection into the finger. I cannot believe there are actually 59 cases of people who accidentally injected it in the wrong place, but nevertheless, out of 59 cases, 30, half of them were untreated, no complications, no necrosis. This study is actually, for a while, it was thought that it's not a great idea to use lidocaine with epi for nerve blocks, because when you do it on fingers and there's no much tissue, people were afraid that epinephrine injection will cause necrosis. Again, 3,000 cases, no complications. This is for intravenous use of epinephrine for asthma exacerbation. Again, 220 patients, some had extravasation, 0 necrosis. Finally, this is just administration of extravasations for vasopressor use, for which we use it in ICU. Again, 270 cases, 1 occurrence of skin necrosis, not too much. That's for peripheral. That's a bigger study, 734 patients, 19 cases of extravasation, 0 necrosis. I hope you see the trend. So we had 1 case, no significant damage, thousands of cases. So I would seriously, I hope if anything comes out of my little talk today is consider benefit and harm with everything you do, including central lines. And yes, benefit of using central line, you prevent extravasation, but with using central line, not only you jeopardize, infection control issues, but you also have other complications like bleeding and pneumothoraces and other things that we usually don't talk about. So going back to our historical reference, to improve is to change, to be perfect is to change often. So medicine is a very conservative field. We do things just the way we always used to do them that way. If we want to get better, perhaps we need to reconsider our practices. And I understand we'll do the questions in a little bit.
All right, good afternoon. My name is Dan Robinson. I'm one of the hospital medicine physicians. And I'm sure that y'all will be surprised to learn that I'm going to be continuing a lot of what Dr. Zubelevitskiy was saying. I've been asked to talk about central line infections when it pertains to having people on the floor itself. And as Dr. Zubelevitskiy mentioned, having no line means having no infection. Obviously, most central lines are not going to be placed on the floor. They're going to be placed in people moving out of the ICU or out of the emergency room. So our job on the floor is early removal, early identification, and looking at alternative forms of access. The big key with this is that we have lots of options when it comes to delivering the medications. I think one of the few exceptions to that might be vascular access for hemodialysis, at least temporary hemodialysis, your VASCAS and that sort of thing. But when you receive a patient with a central line, either from the emergency room or from the ICU, at that point, we reconcile a lot of things, medications and treatments. And I think one of the things on that checklist that should be is access. Obviously, if the person still needs that line, evaluating whether that line was placed emergently or urgently and needs to be exchanged. And then obviously, if that line doesn't need to be there, can we provide different access? Especially considering things like long-term IV antibiotics or things like that, having midlines placed or other options there. Once you have adequate peripheral access, looking at removing that central line safely would be key. Part of that early identification would be partnering from the physician side, partnering with our nursing colleagues to remove any sort of soil dressing and change that appropriately. And again, I think Dr. Mannepalli and some others had mentioned having regular chlorhexidine baths for those patients to make sure that we keep those areas clean. Frequent evaluation of the line site to identify any sort of signs of infection or impending inflammation like erythema, tenderness, swelling around the site. And of course, if you see those signs, early removal would be key. And then lastly, of course, is the alternative access. You have to evaluate the need for IV medications. A lot of times we partner with our infectious disease colleagues. Hey, do we need to keep this person on an IV antibiotic, or can we start the process of switching them to our oral regimen once we've identified source and provided source control? And then, of course, evaluating if they still need an IV class of medications, then peripherally, or if they need it long-term, evaluating at that point whether or not they can have a midline. And of course, as always, if a patient does need outpatient antibiotics, our infectious disease colleagues, it's becoming policy that is a consult, as most of us are primarily in the hospital. If a patient's going to need these things in the outpatient setting, we need outpatient folks to be able to follow that and provide the appropriate labs and monitoring that those patients would need. So just really continuing what Ken had been saying, number one, do you need the line? Number two, if the answer is no, go ahead and get rid of it. But number three, if they do need the line, trying to figure out alternative forms of access is going to be key for preventing these types of things on the floor. So, and again, I think we do questions at the end, but if y'all have anything, just let us know. And with that, I'll hand off to Sarah.
All right, I am Sarah Ostradius. I am one of the laboratory operations managers here at the hospital in Gainesville. And I will be talking to you about how the laboratory kind of helps support our CLABSI initiatives here with the hospital, and how we can help gather data and help you all to identify areas where we can lower the CLABSI rates as well. So with that, one of the ways that we support this is, as we're drawing the blood cultures, one of the identified measures that we found was to use the diversion devices. And the diversion devices is a device that we use prior to collecting the blood culture that actually diverts a very small portion of blood prior to the blood going into the blood culture bottle. And this diverts off the bacteria, the initial bacteria from the skin that might not have gotten captured with the initial cleaning process. And that helps us to prevent culturing it in the bottles, so that it's not a false positive, basically. That's what we're trying to avoid with those. We started this in the hospitals here with NGHS back in 2021, and we saw a really quick win on this when we started using the diversion devices. It was really great. We saw about a 4% decrease system-wide with our contamination rates, which we were really, really excited about that. Since then, our system-wide contamination rates have remained about pretty consistent, about 2.1% system-wide, and we know that we can decrease this still. We know that there's still opportunities here, and we know that this is true because our utilization of these diversion devices is not quite as high as what we would want it to be across what the system is. While initially we started off using these diversion devices about 50% of the time, our goal is to use them about 85% of the time, and right now, it depends on which location we're at, but we're somewhere between 70 to 85% of the time, depending on which hospital we're looking at. So that's one of the opportunities that we've seen across our system, but we have seen some really big wins with using this device. All right, so how the laboratory supports the CLABSI rates. The hospital put out this goal to lower our CLABSI rates. And when the laboratory looks at this, my first reaction is, I promise I will not place a central line. I don't know how to do that, actually. So I promise I won't do that. But the better way that I can actually help support that is to properly train our phlebotomist for when we're collecting the blood cultures, to do our hand hygiene practices, to clean the sites properly, and to make sure that we are reducing the risk of the skin contaminants prior to collecting those blood cultures. And then the ask, and what we can also help support, is to share that information with anybody else who is maybe collecting blood cultures as well, because I know that we do have some nursing partners and some other, I think the EMS partners in some of the EDs that we have here in our system also do some blood culture collections. So we can help support by offering that information to you all, that, you know, the best practices is the hand hygiene and the proper cleaning prior to the collection, so that we can lower that contamination rate, lower those false positives, and that's how we can actually help support lowering that CLABSI rate. Blood culture collection sources. Multiple data out there showing that the best locations for us to collect for blood cultures is going to be on the peripheral venipuncture. There's some convenience associated with collecting it from the peripheral IV lines or just from line collections, and it's really not recommended. There's a higher risk of contamination with that. It's harder to clean the sites properly. When you have that, you also have that buildup of the biofilm when you have those IVs that have been there for a couple of days. And so then the fear would be that you would be culturing really that biofilm than you would be to actually getting the true infection that might be there. So I understand from a patient care and patient experience part of it, they don't want to be stuck any more than they really want to be stuck. And I understand that, I really do. But really for best practice, it would be through venipuncture would be the best way to do that. And to collect it from 2 different locations would also be best practice for that. So when you see your phlebotomist come in there and they're drawing one from the right arm and one from the left arm, that's why we're trying to do that. We're not just sticking them just to stick them because we like to make holes in patients. That's not the goal either. We really are trying to do our best practice here. And then the other part of it is that the catheter from the lines should not be collected either. It's not ideal. Again, we have the potential of culturing that biofilm and not identifying that true bacteria infection that might be present. There's some studies out there that are showing that it's maybe not the best information that you might be getting for a clinical perspective of what you should be treating on that. So it's just not recommended that send us the catheter tip, not preferred. So when we're lowering the contamination rate and we're celebrating our successes, These are all the things that we're doing with our team. So we bring in experts to train. This is going to be my phlebotomy leads, my phlebotomy trainers are going to train, but also the manufacturers of the diversion devices. They have a whole team that is willing to come in and help train as well. So, for example, our current device, the Curin device, they're on a 6-week rotation with our phlebotomy team. They come in every 6 weeks. They do retraining. They do competency. They work with our team and just make sure everybody's comfortable with that. They are more than willing to work with any of our locations within the ED, on the floors, anybody who is interested in that information. So if your team is interested in that, let me know. I can coordinate that training that you might be interested in. Education is a big part of it. I know that sometimes it's not as effective because you think that you're doing the education and then it doesn't go anywhere. We do a lot of measuring of the compliance and sharing that data with our staff. And then we share that data and we celebrate that with our staff. My staff love food, it turns out. So we hand out a lot of prizes, a lot of candy. We celebrate them when they have those low blood culture contamination rates, when they have that high compliance with using the diversion devices. And we really celebrate them doing a great job. And I would encourage that if you're working with your teams and you're making sure that we're celebrating them and those contamination rates are low, that you're celebrating that with your teams as well.
Good afternoon. My name is Christy Hinchliffe. I'm one of our critical care nurse directors, and this is Nadia Prince-Williams. She is one of our acute care directors. All right, so we are going to start out with a couple of things that I want to point out. We've heard most of this, but CLABSIs are one of the highest costing hospital-acquired infections. So, of course, we want to reduce those. And studies show that most CLABSIs can be prevented by utilizing a best practice bundle. So we're going to talk to you about that best practice bundle. So part of our bundle components is our pre-insertion. We want to evaluate the need for a central line before we insert it. And we're going to partner with our physicians, of course, to do this as the nurses at the bedside. So if they have poor peripheral venous access, we've had multiple failed attempts, and that's a need that we would look at. If they have long-term IV antibiotics that they need, greater than 4 weeks, they would need a central line. Or if they're receiving any high-risk medications that can cause damage to the tissue if it's infiltrated. But of course, Dr. Zubelevitskiy talked to us about that, so we have opportunity there as well. Then for insertion, we want to look at our skin prep. So we want to clip the hair that's around the insertion site. We do not want to shave it. Shaving increases the risk for infection, so we want to make sure that we clip it close to the skin. We also need to make sure that we cleanse the area of the insertion using a single-use sterile applicator containing CHG, and if there's an allergy, of course, we would not do that. We also want to make sure that we use our barrier protection. We want to use maximum sterile barrier precautions, sterile gloves, cap, gowns, masks, full body drape covering the patient, and only leaving exposed the insertion site. And then as the bedside nurse, we also want to partner with our physicians to help in that site selection. We want to avoid that femoral access if at all possible.
Thank
you. Or you made it.
You do it. Okay. So again, my name is Nadia Prince-Williams, and I am the acute care director for the medical units. So just to follow up from Nicole when she presented, especially at NGHS, we saw that 14 of the 23 CLABSIs that occurred was linked to the maintenance aspect. So just really working with our clinical team, especially our nurses, to really focus. Again, this is an interdisciplinary approach with bundles. So the first thing we want to do is replacing emergent line. Just by the premise of it, more than likely it may not be in the most aseptic background or environment. So we need to get that. Follow our policy, get that out, get it replaced. Also, we really want to stress line necessity. And I just want to highlight that. We also saw that we had an opportunity with multiple lines, just like our prior presenter indicated, multiple lines, multiple avenue for CLABSIs. So really talking about partnering with our physicians, making it a part of our workflow and our standard work to really address that and really weigh the pros and cons as we look at that. And then leveraging our VAC team to really help with that also. Can we use a midline? Can we use a peripheral? What is the best? Really weighing that. And then scrubbing the hub. We can use the CHG or the alcohol. Everything has its protocol for the CHG. It's 5 seconds, 5 seconds, 5 seconds scrub, 5 seconds dry. Alcohol, it's 15 seconds. So really making sure that we're being intentional and mindful. Again, as our prior slide indicated, CLABSI reduction is truly in our hands. And then we want to talk about our disinfectant cap. One thing that I was informed by our bedside team, I had the premise that the Curus cap had CHG. And it doesn't. It had the alcohol. So I'm like, oh, interesting. But also making sure a bedside team member know it's a one-time use. You access that line, it goes. Just really tightening our practice as we be super vigilant and protecting our patients. Also with our dressing change, we have to make sure we're recognizing the need. Our policy may be 7 days, but it's that PRN. Make sure that timely intervention and keeping that vigilance of that site and that line. And then our daily CHG treatment, really stressing treatment. This is a part of the treatment for this patient as we continue to maintain these lines. And something that we, as a nursing team, we want to focus on, we have the CHG package. It may have, I think it's a total of 3. It's using all of it, making sure we educate our team and the importance of correctly doing it for it to be really impactful. And then changing our tubing per our hospital protocol. And this is guided. Is it continuous? Is it intermittent? What are we administering through the lines? That's all contingent on how often we're changing those tubing. Again, all central lines should be assessed for the need and removed promptly. If it's not needed, we should be partnering and having that conversation consistently. It's all in our hands, and it's truly an interdisciplinary approach, and we all have to really own the part that we play to continue to protect our patients.
All right, I think we're going to have Dr. Mannepalli come back up now.
I'd like to thank all our speakers for sharing their perspective. And as our speakers have already mentioned, zero CLABSI is achievable, and CLABSIs result in significant patient harm, and we can't do it alone. We need multidisciplinary collaboration. We've heard the term bundle. And what are these bundles? These are evidence-based best practice, and each component or each element in that bundle plays a very significant role that we have to be compliant with each one of them if we want to see the results. And again, all of these have already been covered, but I'm just going to highlight few of our opportunities based on our CLABSI data. For elective central line placement, CHG bathing, or treatment, as we're calling it, prior to insertion, that's an opportunity we identified, very low-hanging fruit. And there are indications for central line, and there are indications for midlines. As our speakers have already mentioned, looking at every type of line necessity, not just central lines. We have had central line infections where the origin was from a peripheral IV or an arc line. That's why if you see, Nicole mentioned that CDC will be changing the definition soon. And that's exactly why they're doing that. Because when health systems are reporting CLABSI, we are under-reporting bloodstream infections that are occurring in a hospital environment. And hospitals that have already started looking at bloodstream infections in all patients who are hospitalized 3 days and more, it's actually 4 to 5 times more than the CLABSI numbers that you're seeing now. And I think when we looked at, we're pretty close to that as well. 5 times the CLABSI numbers you're seeing if we start counting every bloodstream infection in a hospitalized patient after day 3. And having an insertion checklist, we do have an insertion checklist here, including what should be done pre-insertion, what should be done during the insertion and post-insertion, and making sure there's a timeout, and ensuring that the whole team actually is trained, competency has been checked, and if any of the, whether it's the type of the line, it's the infusion set, anything changed, then they're retrained in that, and ensuring again that anyone who is part of the procedure is empowered to speak up if there is a deviation noted. And I cannot stress the importance of hand hygiene. This is just an example of a checklist. And use of gloves does not replace hand hygiene. Very, very important. We see that often, we hear that often. And using ultrasound, this is part of our bundle, using ultrasound for central line placement, except in emergent situations. Very, very important. And I'm aware of some of the data that's come out that femoral lines are necessarily not at increased risk, but this was reviewed by our CLABSI team with input from physician and nursing leaders and our vascular access team leaders. But our CLABSI bundle at NGHS still recommends avoiding femoral site, and if femoral line is placed in emergency, removing it as soon as possible once an alternative access is established. This has already been covered about the type of PPE and maximum barrier precautions, so I'll skip through this slide. And removing all non-essential catheters. I cannot stress the importance of that. And inspection of all catheter sites, not just central lines, on a daily basis. Because as I mentioned, even if it's another site, patient can still meet CLABSI definition if they happen to have a central line. A dialysis patient with a dialysis catheter and a peripheral IV, infection can start in the peripheral IV, but if they get bacteremic and we can trace it back, that will be a CLABSI. And we use transparent dressing so that we can actually visualize the insertion site. This is, again, very important. And there is a phlebitis score that was recently approved within the last year, if I'm not mistaken, here at NGHS, that our nurses should be using to ensure that all lines are inspected, not just for necessity, but also how the site looks. Because even as part of, when we see patients, we see there is some redness, there is extravasation, they're complaining of pain and swelling. That should be acted upon immediately. Otherwise, that can lead to thrombophlebitis and eventual bacteremia. There are scoring systems. This is a CLISA score. This is one example of the scoring system. And we need to provide guidance what to do if the score is higher, 2, 3, which means there is increasing redness, pain, and swelling. What is the recommendation? Nurse to escalate to the physician, and what has been done about that line? Has the line come out? Is it staying? Why is it staying? And how are we going to follow up on that? This is our phlebitis score, and should be used for all vascular access catheters. And for those catheters that are tunneled, it's also sometimes patients can develop tunnel infection where there can be some redness along the tunnel. So as part of our exam, looking at those sites to ensure that we're not noticing any signs of early local infection, so that if we do, then we intervene right away instead of waiting until they get bacteremic. And this is one of my favorite papers. I got this from that, where it's not about putting this in policies and papers. It's about how we implement them. In this particular health system, they use this phlebitis or CLISA score for not only just part of nursing regular workflow, but also that they have to document actually what the assessment is. Any of those higher scores have to be escalated to the nurse and the provider, and the charge nurse is responsible for making sure that they're actually reviewing the high-risk lines, and there's regular multidisciplinary discussions, and also infection prevention, nursing, physician, bi-monthly multidisciplinary rounding to actually look at the performance and where things are. So very, very important to have operationalized these so that there is very close monitoring. Daily CHG treatment, our colleagues have already mentioned about that. Very, very important to prevent infections. But how do we operationalize that? Who gives that daily CHG bathing? Is it nursing? Is it PCT? Have we trained them? Have we checked their competency? And are they getting annual, competency checks again? How are we monitoring that? And is the charge nurse responsible for daily for all the patients with central lines to check before the shift ends that everybody has had a CHD treatment, and if they did not, what's the reason? Because by the time we're looking at CLABSI numbers, it's too late. We should be monitoring bundle compliance on a daily basis. And scrubbing the hub. The disinfected caps are just part of the bundle prevention, because even if you use a disinfected cap, we should be disinfecting when we open that. We should still be cleaning them. We should be scrubbing the hub, because that's how the bacteria that are outside can easily get intravascular, intraluminal, and lead to bloodstream infections. SHEA guidelines recommend that we should scrub the hub for 5 seconds. And we should be monitoring compliance with this as well. And for SHEA guidelines, they recommend a combined product with both alcohol and CHG. And again, as I mentioned, I'm going back to one of my favorite papers here. What they did was they involved patients and families, where they count. The prior guidelines used to say 15 seconds. So what they did was they encouraged patients to count with the nurse as they're scrubbing the hub 1 to 10. They also had these pictures to show how a contaminated hub looks like using the closure, where it's illuminated versus not. And again, the compliance was monitored on a regular basis by the nursing leaders, and again reviewed in multidisciplinary rounds. Dressing changes. Our colleagues have already covered that. That should be part of our daily assessment when we see the patient. Dressing site looks okay. Has it come off? Is it soiled? Is it wet? Instead of waiting 7 days, then that dressing should be changed immediately. And Sarah mentioned about blood culture diversion devices. Ordering blood cultures only when clinically indicated, because if you noticed, majority of our pathogens are skin pathogens. And recently we had a shortage of blood culture tubes, but what we identified through that was we had a 60% reduction in blood culture utilization. So were we really overusing before this? So again, very important to not draw blood cultures from the catheters, because you may be not getting a good sterile specimen. Use the diversion device and only order blood cultures when clinically indicated. There's some additional approaches for SHEA guidelines as listed here, like antibiotic locks, antimicrobial impregnated catheters, but we need to get the basics right. There's so many low-hanging fruit as we look at the data, whether it's the daily CHG treatment, removing the emergent lines, line necessity, scrubbing the hub, that these are additional approaches that once we get our basics perfect and we're still having a problem, we can explore. And cannot stress the importance of looking at every vascular access, not just central line. And even peripheral IVs that are placed emergently should be replaced. Conducting daily inspections of the site, and again, if they're not needed, removing them, because if CDC goes live with the new definition, it applies to every line. Once they finalize the definition, it may apply to even patients who don't have a vascular access. Any patient who is hospitalized for day 3 or more with bloodstream infection, we will have to report. And again, as I mentioned, if we're just looking at infection control data, that's too late. We need to be looking at bundle compliance. These are the reports that all the nursing physician leaders should be looking at. Pick the top 5 bundle elements we have an opportunity and monitor the compliance, share that with our bedside nurses, techs, providers, and ensure that those are the ones we are focusing on. And there's several ways. If you look at the literature, there's so many different ways we can engage or we can monitor, engage our bedside nursing staff. And this is one of the examples. So this is pretty widely published in the literature, the K card, where again, top 5 things you pick, and that's part of daily discussion in patients with vascular access. And this is also another one of my, I think I've had this slide for 10 years now, or I don't know how long, but this one, again, drill down tool. Pick up your top 5, top 3, whatever it is, and ensure you're not just looking at the infections, you're looking at the bundle elements and what's your compliance rate for each unit, each floor. And CLABSI prevention is possible. Again, study after study has shown that if you're compliant with the bundle, you can get to zero and you can see the reduction. And CLABSI, zero CLABSI is definitely possible. But it's important to engage everyone, educate, execute, continue to evaluate how we can improve. Now we'll all take questions. Thank you.
At this time, we can take questions from the audience. We have our panelists who will be ready to answer those questions. If you do have a question, please raise your hand, and I'll come to you.
We've got one down here.
This question is for Sarah. I'm very impressed with what we've done with contamination rates at blood draw. And I know we've all heard that it's going to be dropping from 3% to 1%, so more work is to be done. But you've done a great job with your phlebotomists, not only educating them and celebrating, but making those that drew a specimen contaminated as aware that they were the person. Have we thought about taking that out to the draws that were not done by your phlebotomists? It just seems like your program's working really well, and I'm able to see the behind the scenes statistics and know that there's some opportunity for those non-phlebotomist draws. What's our plan for that? And maybe we know how.
So on the monthly basis, we do, there's an email that goes out to a group. I don't know who all is on it. We have like a whole big blood culture contamination group. I know there's ED leaders that are in there because there's a lot of blood cultures that are drawn in the ED, but there's other people that are involved in it too. And we can break that down by the different collectors, by the different floors, by the different sites and everything. If you are not on that list and you are interested and you want to see how your floor is performing, if you have nurses if you have nurses that are collecting blood cultures on your floor, I'm happy to share that information with you. It's not a secret. So you can reach out to me in the lab, and I'm happy to work with you on that, and we can work on those numbers. Does that help?
And this is very important because staph epi or skin bacteria are one of our major pathogens. And Nicole, correct me, but if it's in 2 bottles, even if it's a skin bacteria and patient has fever, a central line, we report that as a CLABSI, even if the clinician ignores it as a contaminant and decides not to treat.
That is correct. And a lot of the common commensals are really hard to tie back to another infection. So staph epi is one of them. And so when we get those have to be caught as a CLABSI.
Okay, any other questions? Just raise your hand. It looks like we do have some online as well. I'll go ahead and read those. Okay. First question, is the term CLABSI going away given that all nosocomial bacteria may be considered significant?
So currently, NHSN has certain hospitals that they're rolling this out to, and we are not one of them yet, but it will be coming. And so they count CLABSIs, and then they count, it's called HOB. So if you ever hear that, it's called hospital onset bacteremia. And so right now they're counting both of them. I don't know what's in the future, but right now there is both of them.
Thank you. And we have a second question. Can you give your thoughts about culturing catheter tips once removed?
I can give a little bit, and I think a bunch of us can talk about it. Culturing catheter tips does not rule out the CLABSI, unfortunately. So,
do you want to add
anything to it?
Does that have anything to add to that?
Do you?
Okay.
Exactly. It doesn't rule out the CLABSI, and it doesn't. There's limited information that it can provide. So, sometimes those catheter tips will just culture the biofilm that's on there, and so that may or may not be what is appropriate to treat on, and it might not be the information that you're looking for. So there's a lot of new data and papers and supporting documents out there that just say that that's not the best practice to be culturing those catheter tips anymore.
And we can actually contaminate that tip as we're pulling the line out. So again, you won't get reliable information. That's one of the updates that's coming, if I'm not mistaken, from the Diagnostic Stewardship Committee, which they just recently approved removing that as an option to order.
Do you have a question?
Yes, hi, I'm Erin from the Vascular Access team. I hear a lot about HOB all the time, and I know we've been working really hard on our CLABSI bundle together. Would a peripheral bundle be something you're considering making next?
Yes, definitely. I think we, again, as Nicole mentioned, we're in the transition phase right now. We're not one of those facilities, but eventually, the way this is going, for our system this year, CLABSI prevention is our system initiative. In the near future, at some point when CDC finalizes all of that, yes, we'll be moving away from that whole CLABSI, but we should start right now looking at every access. And yes, we should be looking at infection prevention bundles for all types of vascular access.